Thank you, Christophe. And I'm happy because this presentation follows directly what Christophe presented about the luteal phase. Now, let's go back to basics. And I think we always can learn from nature. Let's go back to nature. Progesterone, where does the name come from? Progestation, for pregnancy. It's a hormone for a pregnancy. And we know that it's producing in the luteal phase that the values measured are around 13 to 19 nanogram. And we know it's working on the endometrium. This is the basic knowledge that we have. We also know it creates what we call a secretory transformation. Now, what is a definition of a luteal phase defect? You would say, initially, 1949, we said, look, if a patient is having premature bleeding, we are dealing with a defective corpus luteum. On the other side, if you are a poor responder, you are going to menopause, you also have a short cycle. That doesn't mean that you have a corpus luteum deficiency, you have a follicular deficiency. So what was the prevalence of luteal phase defect in an unstimulated cycle? The answer is it was around 8%, as you see. So time passed by and we had a better understanding on the luteal phase defect. And a few years ago, 30 years ago now, the values came out. So we started measuring progesterone in the luteal phase and we said, look, if in a natural cycle, in the mid-luteal phase, you have progesterone values of less than 10 nanogram per ml, you are dealing with a luteal phase defect. On the other side, the systemic progesterone levels do not always reflect the status of the endometrium. We are interested in the status of the endometrium initially. So today, the value, the really objective assessment of the luteal phase defect is a biopsy of the endometrium where you have an out-of-phase endometrium by more than 2 days. Now, we speak about what we call luteoplacental shift. What is that? We know that around 7 weeks, you have the corpus luteum, which is taking over the function in natural cycle. I'm not speaking about an HRT cycle. You have the corpus luteum taking over the function of progesterone production. Now, we are not here to listen to a natural cycle because we know that the moment we start stimulating a patient, we do create an abnormal environment. What happens? If you take a look to all the stimulations that you see here, if you have the long agonist, you have your flare-up, you have the desensitization, you have your suppression, and you have your stimulation. Short agonist, you start almost simultaneously. An antagonist, you start your stimulation, and the moment there is a risk for imminent premature LH rise, you administer the antagonist, usually day 5 or day 6. So you see the follicular phase among all these cycles is completely different. But the moment you go to the luteal phase, all of them are identical. Why is that? Why do we have a luteal phase defect in all stimulated cycles? The reason is very simple. Because we create a rapid increase and a rapid decline of the steroids. If you compare in a natural cycle, you reach a plateau and you go down gradually. It's like, I would say like a Formula 1 car. You go very fast, you blow up the engine and you stand still. Rather than an old diesel engine, the way Professor Velasco is driving his car, that it goes and goes on and on and on for a long period of time. So basically, this is the difference between a stimulated cycle or a natural cycle. You reach sky-high levels of hormones, but as fast as you went up, you go down. But why? Why do you go down so rapidly? Why do we have such a rapid luteolysis in all stimulated cycles? The answer is very simple. Because the moment you start stimulating a patient, obviously your steroid levels go up. The moment your steroid levels go up, you create a negative feedback. Your high progesterone levels, they create a negative feedback, they suppress your LH, and then you have nothing to stimulate the corpora lutea which are present, because your LH is suppressed. Now you would ask, how do you know that the LH is needed and the LH is suppressed? Very simple. This is a beautiful publication by Marco Filicori. You see, in the beginning of the luteal phase, you have a high amplitude and high frequency of progesterone. Once you go towards the end of the follicular phase, there is almost nothing. There is no activity of LH. So in the beginning, it's very active. Once you go towards the end, if the patient is not pregnant, if there is no ACG, because the ACG will rescue the corpus luteum, the patient will start bleeding. What happens in a stimulated cycles, as we have published, you have no LH. Your LH is completely suppressed. Now here, this is a crucial point. When we speak about the uterus of a woman, and I'm going to tell you a very funny sentence. The endometrium, and this sentence is not from me, by the way. This sentence is from Claire Bourgain, who was in the 80s and 90s really extremely known for the endometrial receptivity. Now, she told me once, and at that time I didn't understand it, but the more I think about that, the more I understand why she told me that. During a 28 days of cycle, she said, the uterus is the worst place for an embryo to be in. The uterus is the worst place for an embryo to be in. Come on. The uterus has been designed for a pregnancy, and we say, this is the worst place to be in. Why did she say that? Because in these 28 days, only 2 to 3 days, the endometrium is receptive. If you have the best embryo, you put it any time outside the so-called window of implantation, you will fail to have a pregnancy. Now, how is this window of implantation defined? And here, the detail is important. And this is something I would say 99% of us neglect. This is defined based on the hours of progesterone exposure. So your endometrium starts to change based on the hours of progesterone exposure. Now, what does progesterone do? Obviously, secondary transformation. It's working on contractions. We know that if you remove a corpus luteum before 7 weeks, you will have a miscarriage. But if you keep the if you remove the corpus luteum, you give progesterone, you rescue the luteal phase. So progesterone is the hormone to administer. Now, it is also, and this is an important point, it is also working on the immune system. I'm going to tell you something interesting. If a patient is getting pregnant, she's receiving half of the genetic information from someone who is usually not related to her. It's like a donation. It's like a transplant of an organ. Can you take any organ transplant to anyone? No. So what does the body do? The human body has to suppress the immune system in order to accept that embryo. It means the progesterone is also working on the immune system. Why do you think a patient who is ovulating has a rise of temperature? We all learned that at school, right? 0.5 degrees rise of temperature. Why is that? Most probably to protect a woman also for infections with this half a degree. Did you know that a woman in the luteal phase is more receptive to get infected with HIV than in the follicular phase? Because of the presence of progesterone. So progesterone is working on the immune system, and this is a point which should not be neglected. Of course, it's also working on the contractions, and we know this has an impact on the implantation. Progesterone, of course, it helps. There is no debate that progesterone is helping the outcome. But the next question would be, how should we administer this progesterone? Should we give it orally? Should we give it vaginally, subcutaneously, intramuscularly, rectally? If you find any other mode, tell me, I'm going to add it here. So there are various options how we can add progesterone. But which is the best way to go ahead? Let's start with the most difficult one. The intramuscular, yes, of course it's working. You have seen from Professor Bloquet previously the DIVINE study that intramuscular in the HRT cycle is superior to vaginal. But let's have a look into that. And I'm very happy he presented this data because here is exactly where you see mistakes which are being done in studies. It works, but those among you who have used it would agree with me that you have pain, higher temperature. It needs to be administered by a doctor or nurse or someone else. Very painful because of the oil which is inside. Last but not least, There are many cases of acute eosinophilic pneumonia with patients being admitted to intensive care units. Subcutaneously, results have shown similar results. Studies intravascular versus vaginal, similar results. But you might say, meta-analysis, heterogeneity, maybe it's not correct. Let's go back to basics again. If you give progesterone vaginally, what is happening? You have an absorption of progesterone in the vaginal mucosa, in the collateral blood vessels, going to the cervix, going to the endometrium, and going to the myometrium. So in fact, what you have, it takes you 4 hours until you have absorption in the places you want it to be. The thing is, you also have a systemic absorption of progesterone. Now, the systemic absorption of progesterone vaginally is around 7 to 8 nanogram per ml. So it's not that you have no systemic absorption. If you take a look at this study which Professor Bloquet looked at, DIVINE study, HRT, very simple study, straightforward. HRT, intramuscular progesterone, vaginal progesterone. Good, and up to now everyone is happy. So you have one variable, intramuscular progesterone, vaginal progesterone. But the first issue we need to think about is how is the absorption done of intramuscular progesterone and vaginal progesterone? We know if you receive intramuscular progesterone, it takes you 5 to 10 minutes until you have it in your systemic circulation. The intramuscular absorption is very rapid. Remember, the time of progesterone exposure defines the window of implantation. So the absorption between vaginal and intramuscular differs, but the difference would be 2 to 3 hours. So you might say in 120 hours, 2 to 3 hours is neglectable. Yes, I agree. But what if I would have told you that the intramuscular group received 24 hours more and started earlier with the luteal phase than with the vaginal group? Then we have two variables. One variable is intramuscular versus progesterone. The other variable is the fact that you started 1 day later. And you can see here, they started in the afternoon on day 5, they started in the afternoon of day 6. So you have two variables. Two variables, vaginal, intramuscular, and the time of absorption. And the third variable actually is vaginal, the time of exposure, because they started 24 hours later. And these are the papers which are being published in good journals. FNS is not as good as RBM Online, but it is being published in a good journal. So we have to be critical. This is a beautiful study, and this is highlighting the importance. And I think if you want to take anything from this presentation, take a look at that. This is the gene expression of the endometrium, and suddenly, after approximately 120 hours, you have an opening of the window of implantation. It means your window of implantation is based on the hours of progesterone exposure. And this is something we should keep in mind. And as fast as it opens, as fast as it's closing also. So you see, this is the runway that your embryo has in order to implant. And we need to understand and respect this if you want to do any studies. If you have wrong timings of synchronization of your embryo with the endometrium, you will have a mismatch. Now, looking into absorption of progesterone, and this is what I have mentioned previously, you see, if you look at the plasma levels and look at the vaginal progesterone, if you take a look at the plasma levels, looking at intramuscular progesterone, you see immediately in about 20 minutes, you have 10 nanogram. 20 minutes, which is a high dose. So all these things need to be addressed before you want to compare two different variables. And even if you don't respect this, you need to start the luteal phase on the same time and not later. And that is an important issue. Now, one of the questions was, and today, this is a big topic, the systemic progesterone levels in the luteal phase. And you're gonna laugh if you go through all the published data, because it's funny. You see, some say you need to have a progesterone level of 20. Now, some say it should be between 22 to 31. Some say 11 or 9 or 10 or 20, but if it is more than 18, you have less pregnancies. But it should be 20 to 21. Come on. What are we doing? And Labarta 9.2, 8.8, which essay? What time of the day? How many hours after the administration? You see, all these things make us taking decisions. So we need to understand, if you speak about a cutoff level, do you speak about the cutoff level of vaginal progesterone? Because the vaginal progesterone, most of it is absorbed vaginally, and you have very less in the systemic circulation. If you take on intramuscular, almost all of it in the systemic circulation. If you take a look at the natural cycle, imagine the anatomy of the uterus and the ovaries. Those of you who operate laparoscopically would know you have a lot of collateral blood vessels between the ovary and the uterus. So anatomically, the ovary is very close to the uterus. So if you measure in your blood in a natural cycle 7, it's not that it's 7 around the uterus. Around the uterus, it would be maybe 30 or 40 nanogram, because it's anatomically very close to the uterus. But if you measure it, let's say orally or subcutaneously, intramuscularly, you're dealing with a completely different value. So here, if you take a look at the uterine levels versus systemic levels, you have huge differences between what you would measure around the corpus luteum as compared to what you would measure here or in the jugular vein. And all these details at the end will make the difference. Now, oral progesterone, is it effective? Again, I think in the near future, we will hear more data. The official statement is oral progesterone, natural micronized progesterone, is not effective because it's going to be broken down through the liver, first bypass effect, 5-alpha, 5-beta, as published previously, has no impact on the endometrium, point. But I think there is a place in looking into that in future, because progesterone, as you have seen, has 2 functions. One function is locally, the other function is systemically, immune system. There is a beautiful publication by Chakmakian in 87, 88. They look to oral absorption of progesterone, 100 milligram, and you reach in 6 to 12 hours values between 6 to 8, 9. But of course, Claire Bourgain and Paul Defruit demonstrated that they don't go into the uterus, most probably because you don't reach high enough dosages to reach that area. But what if you would deal with the systemic response rather than local, and you would combine the local with the systemic? But these are all studies which needs to be done. Now, if you take a look at oral dydrogesterone, this is something which is coming. Initially, it came from Ganesh in India, in Calcutta, and Chakravarti also in India. They did 2 studies published in FNS, big sample size. They said, look, oral dydrogesterone can be used as a luteal phase support. And thereafter, company-sponsored studies came, and they said, look, yes, you can compare oral with vaginal, oral dydrogesterone. Again, some studies have biases, heterogeneities, and I think this is leading to many outcomes which might be questioned later. So for example, that study, they have done a study in different stimulation protocols, agonist, antagonist, REC-FSH, HMG, whatever trigger you want, whatever day you want to transfer. So many variables that at the end, if you draw conclusions, you will have too much heterogeneity in order to be able to draw any conclusion. But this is a paper we published 14, 15 years ago now in Human Production, where we looked to oral dydrogesterone in menopausal women, and we took endometrial biopsies, and we demonstrated that basically the same patient with vaginal progesterone has an in-phase endometrium, and the same patient with oral dydrogesterone seems to have an out-of-phase endometrium. Should we add estradiol? Because in the luteal phase, estradiol is also present. The answer is no, because simply in the luteal phase, the estradiol receptors of the endometrium are not active. Should we add ACG? Of course, you can add ACG, but you know better than I do that you increase the risk of ovarian hyperstimulation syndrome. When should we start the luteal phase support? Should we start the day of trigger? Should we start the day of egg retrieval? Should we start on day 3 when we transfer, or should we start on day 5? The answer is, if you start on the day of ACG, it might be like you have a premature progesterone rise because you're exposing the endometrium to progesterone, which is not meant to be. But if you would start on the day of egg retrieval, your endometrium is already exposed to progesterone because after the trigger, your progesterone already is increasing. So 12 hours after the trigger, you have sky-high levels of progesterone. So if you want, you can start after the trigger, after the egg retrieval. But the ACG that you administer is covering the luteal phase for at least 5 to 6 days. So you have time between after the egg retrieval or day 3 to start your luteal phase support. So there is a window between the egg retrieval and day 3 where you can start your progesterone for the luteal phase support. How long should it be administered? Now, should you stop when ACG is positive, up to 7 weeks, 12 weeks, during the whole pregnancy, or even after that? The answer is, and you have seen the slides from Christophe, that basically, if you take a look and the patient is pregnant, the pregnancy itself, the ACG is rescuing the luteal phase, so there is no need for continuing. But I fully understand when you stop and the patient has a miscarriage and goes to someone else, yeah, this doctor doesn't know what he or she is doing, he should have taken progesterone and so on. But I think we have solid evidence to demonstrate that this is unnecessary. Very simple, because the ACG, which is produced by the early pregnancy, is rescuing the corpora lutea and stimulating them. Debatable topic, agonists, Christophe spoke about that. As usual, science is dynamic, pro and contra being debated. Now, what about the agonist triggering? Because this is a very interesting entity. And here we see how you can individualize the luteal phase of a patient. Now, if you take a look at the natural cycle, you see you have an increase of your LH. You have a plateau of approximately 14 hours. And you have a decline of 20 hours. So in fact, what you have is around 44, 45 hours that you're ovulating. And I can tell you, we do a lot of natural cycles. This is not the case with every woman. Some women, the ovulation takes 3 days. Sometimes they have an elevated LH, day 3, day 4, until they start having a progesterone rise. So again, this detail makes a difference. But this is a natural cycle. This is a typical natural cycle. When we trigger the final oocyte maturation with ACG, this is what is happening. Because it has a long half-life time, the ACG is very similar to LH, but it contains 27 carboxy terminal peptide, which is giving a long half-life time of the ACG molecule. So you are really stimulating the corpora lutea 5, 6, up to 7 days. But if you go with an agonist triggering, what is happening, you have your LH rise and you have a rapid decline. Now, if you have this rapid decline, what is happening, you have a rapid luteolysis. And we published in FNS, that was 8, 9 years ago, where we demonstrated if you have a patient and you trigger with an agonist, within 5 days after the egg retrieval, the patient has a total luteolysis. That's what we have published. And I have to tell you, I was wrong. This is a wrong publication. Why? Because not everyone is undergoing a rapid luteolysis. So what we didn't understand at that time, that the agonist triggering for final oocyte maturation is not creating a total luteolysis with everyone. It's not that one size fits all. That's a mistake. Now, Professor Bloquel and Professor De Fruy with Nikos Polizos, who's going to speak, I think today or tomorrow, they came out with this paper, OHSS-free clinic, that has been also 11, 12 years now. Then what happened, we published the first case of severe hyperstimulation after the agonist triggering, freeze-all. And after that, many, many other publications came out that the agonist triggering by itself is not eliminating OHSS completely. You still have sporadic cases of OHSS. So we were asking the question, why is that? Why do you have some patients who are having OHSS or no luteolysis after the agonist triggering? And Peter Humeidan came out with a solution of the modified luteal phase support with low-dose ACG, but also Baris Atta and Ayşe Seyhan. Baris is working with us in Dubai currently. They published this paper. They said, look, even if you go with an agonist and low-dose ACG, you still are having patients developing OHSS. So that's not a solution. But then we went back and started understanding the basic physiology. And we saw this pattern of luteolysis seems to be different among women. So it seems that you have a couple of days' time, and maybe we should start looking to the pattern of luteolysis before we start administering this low ACG. So you cannot say one size fits all, I'm going to give everyone 1,500 after 36 hours. So what we did, we started looking to this pattern of luteolysis. We published a few papers on that. And the first series that we published was in PLOS ONE with Barbara Lawrence. We did an agonist triggering, and we started measuring the progesterone 2 days after the egg retrieval. And we saw that patients can have progesterone of 10 to 12, which is a rapid decline, or you can have patients who have 60 nanogram, extremely high level. Now that patient with 60 has no luteolysis at all. She doesn't even need a luteal phase support because she didn't undergo a luteolysis. On the other side, that patient who went in 2 days to 12, if we don't support that patient, she will have a severe luteal phase defect. So it means you can also individualize the luteal phase of patients after the agonist triggering. Then we looked, okay, what are the variables which you can look at this pattern of luteolysis? Then we saw it is really per follicle that the estradiol and progesterone is being produced. You might have the same number of follicles, you might have the same number of eggs, and yet you will have differences in the pattern of luteolysis. So it's really per follicle steroid production which seems to be important. So what came out is that basically you need to have a level, you need to have a certain luteolysis before you start administering your ACG in order to rescue the luteal phase of your agonist triggered cycle. So it's not that you can give everyone the same dose. Let the patient undergo luteolysis. After 2 days after the egg retrieval, measure your systemic progesterone level, and based on that, you can individualize the time, but not only the time, but also the dose of ACG. So if you have a slow decline, you can reduce the dose of ACG, and all that we have published in various papers. Most of the first author of those papers is Barbara Lawrence. So you can go down with ACG as low as 375 based on the pattern of luteolysis. So we published also with Professor Garcia Velasco an opinion paper, also in FNS, some reviews about this pattern individualized luteal phase support. So summary of luteal phase: the moment we start stimulating a patient, the moment we create multifollicular development with gonadotropins, we create abnormal endocrine environment, negative feedback, and the luteal phase needs to be supported. Intramuscular, subcutaneously, of course, the work, should they be the first choice? Absolutely not, because vaginally, this is working fine. Should we look into the systemic levels? Absolutely yes. What are the values? This needs to be further evaluated, but today it seems to be somewhere between 9, 10, up to 20, but we need to distinguish what kind of cycle are we looking at. Oral dydrogesterone seems to be working, but we need more studies to validate that. The duration of luteal phase support seems to be shorter than we usually do. And I think we need to explain this to the patients. And based on the patient's response, we can tell them you take it or you don't take it, but we have solid evidence to tell them the moment ACG is positive, you can withhold it. The agonist triggering, it's a very interesting entity. There is a lot of room for individualization based on the pattern of luteolysis. And the pattern of luteolysis is giving us an idea, the time of ACG rescue, and also the dose of ACG rescue. And the concept in the fresh cycle is obviously personalized luteal phase support based on the pattern of luteolysis of that particular patient. And obviously, if you want to go safe, and this is what we are currently doing, it's better to freeze all and go to a subsequent frozen cycle. Thank you very much for your attention.
Thank you, Professor Fatemi. Professor Lokil, I think we're having a quick session of questions and answers, if you don't mind. Maybe could both of you have a seat on the stage. It's a session covering both presentations. We have the first question, to Professor Lokil, how many days of progesterone do you give to a day 3 embryo? How many days of progesterone do you give to a day 3 embryo?
So 2 remarks. First of all, we we don't do day 3 transfers anymore, or in a very small amount of cases. If we do a day 3 freezing, it means that we thaw the day before the embryo transfer, and then the transfer will occur on the 5th day of the progesterone administration.
So 5 days of progesterone. Thank you. How often in your clinical practice do you measure progesterone on day of or before the HRT, FET, and do you measure it in natural cycles, FET? So,
well, yes, since the publications that came out of Labarthe, we have started measuring progesterone on the day of frozen embryo transfer, in terms of, well, not making it too burdenful for the patients. We don't ask them to come the day prior to transfer, but we let them come both in a natural cycle and in an artificially prepared cycle on the day of embryo transfer.
Thank you. The audience has been very quiet, so I would like to invite a question from the floor.
Thank you. Very interesting session. Question to both Professor Fatemi and Professor Blockeel. What is the evidence at this moment on natural cycle progesterone levels at the time of transfer, and to which extent, you know, like in fed cycles, they have a predictive value or not regarding reproductive outcome? Because it seems, based on what Professor Blockeel was sharing, that from a safety perspective, a lot of advantages seem to be present in moving to natural cycle rather than fed cycle. But the question is, does the serum progesterone story also hold there? And also would welcome Professor Fatemi's critical comments, who may be from a little bit different from perspective.
Well, it's of course a crucial question, but let us start maybe doing some properly designed RCTs instead of what, for example, we are doing now, which is measuring progesterone on the day of FET in a natural cycle, and then start supplementing with, for example, micronized vaginal progesterone or oral dihydrogesterone or whatever. What we should do is, of course, performing an RCT. When you ask, for example, Ine Labarthe, now she says, well, sorry, we are never going to do the RCT anymore because it's not ethical. But I disagree. I think there is not yet enough robust evidence to state that this study could not be performed anymore. So let's do the study and measure progesterone, whether it is low or high, but of course in a correct way. Which assay are you going to use? What kind of moment of the day are you going to choose? You know the studies of Polizos showing this huge difference in progesterone measurements in the morning and then at 8 p.m. At night. So let's try to do that in a correct way.
Can I ask you one challenging question? All of you, everyone in the room. From which level progesterone in the systemic circulation do you have the initiation of secretory transformation? A value? Approximately.
No, I think it's lower.
3?
5?
5? Anyone more? Anyone less? I have the hammer. Okay. I can tell you, this is really funny. So this has been published in, I think, 88, 89, Tchaikovsky. It's Eastern European name, but in the US, in a university, 0.9 nanogram per ml. So it means with 0.9 nanogram per ml in the systemic circulation, we start having a secondary transformation.
But again, what kind of kit was used?
Yes.
What kind of assay?
But you see, Christophe, 3 or 5 or 0.9, that's a big difference. The second thing is we need to define a natural cycle. So when we say a natural cycle, and I can tell you we do hundreds of natural cycles every year, everyone is ovulating different. So if you look to the papers by Nikos Polizos measuring a value and coming with a statement, if you say, okay, after the LH so many days, but maybe this patient needs a longer LH rise in order to have a progesterone rise. You see, all that needs to be respected. The window of implantation is not based on the LH rise. The window of implantation is based on the progesterone exposure. So first, we need to identify a natural cycle. How do you conduct a correct natural cycle? The other thing is, we are referring to Cochrane databases. I'm going to challenge you all. One of the Cochrane databases compared natural cycle with HRT cycle and said there is no difference, as Christophe referred at. There is one paper included in this Cochrane. It's Catoli. Look it up. Catoli, 1994. This paper has never been published, ever. I did my PhD on luteal phase support and I was desperately looking for that paper. I never found it. Why? Because it was never published. It was presented as an abstract in a meeting, so we have no clue about the details. This is the level of evidence that we are having today, unfortunately. And specifically, in our field, when we have a Cochrane, we say we're going to do that. So before we look to the natural cycle, we need to understand what is happening in the basic physiology in a natural cycle. How much progesterone do you need in order to initiate this secretory transformation? And of course, these are all studies, but we need to address that with new assays, with gene expression models, which are available, in order to have a better understanding of this matter.
Okay, I'm taking one more, thank you. I'm taking one more question from the floor, please.
Yeah, so as you showed, the natural cycles have some benefits, lower risks of obstetric complications. And so we're trying to do more natural cycles. So recently, the billing coordinator from our clinic came to me and said, those natural cycles, they cost us 3 times as much, but they cost the patient the same. We need to raise the prices on the natural cycle. But at the same time, we're trying to tell them, you should do a natural cycle. At what point does it become unethical to still, like you said that in your presentation, at some point, does it become unethical to do the program cycles? And how do we encourage it, but at the same time, economically, are able to provide both?
This is, of course, a crucial remark. Well, I'm not ashamed to tell you that we still use between 80 and 90% of HRT cycles, because logistically we can just not organize it in a natural cycle. That's one. Secondly, we rather should search for how to circumvent the problem that we just mentioned, rather than putting the HRT cycle in the garbage. Should we give aspirin, and this is the studies that we are performing now, should we give aspirin to these kind of population? How can we try to trigger the patients in another way and try to have the same results as a natural cycle?
May I just also, thank you. I'm taking 2 more questions that are online that will be very quick, and maybe one observation before we move to the knowledge questions. So the question goes as follows. Why not use as luteal phase support both vaginal and IM progesterone for all and stop measuring progesterone? Would you like to make a comment?
Because IM progesterone has a lot of side effects. It's increasing the body temperature. It is painful. And if you ask me, should it be administered? The answer is clearly no, if there are other modes to reach those levels. But I didn't mention there are very recent publications looking also at the combination of vaginal and rectal. And with rectal progesterone, you have extremely high absorption in systemic circulation.
Thank you. And the second one is, should we stop estrogen administration after FET as there are no estrogen receptors anymore?
That was the meta-analysis I showed you. There is no sense in an HRT cycle to continue giving the estradiol. You might argue in a natural cycle, why is there a drop of estradiol after the ovulation and a rise of estradiol? Now, this drop and rise is meant to control your FSH to select the dominant follicle for the subsequent cycle. So the physiologic aspect on the endometrium is very limited.
Thank you.